Hey everyone, I'm going live today with Dr. Madhu Bagaria, who is an endometriosis surgeon. I'm just going to wait for her to join in and introduce her and myself. So let's wait for her to join the live. She should be here in a minute. Sorry about this. This is taking a minute. There's some technical issue.
Hi.
Okay, Dr. Bagaria is here with
Minute.
us.
Yeah.
Hi, Dr. Bagaria. So, Dr. Bagaria is an excision surgeon with pelvic rehabilitation medicine, and you practice in New Jersey and New York, right?
Correct.
Great.
Yeah.
And I'm Bhakti Soni. You guys know me. I'm a pelvic health physical therapist and owner of Pelvic Elements in Warren, New Jersey. So today we are going to chat about top 3 questions that patients have after an excision surgery for endometriosis. All right. So are you ready, Dr. Bagaria?
Thank you for inviting me. This is good.
Perfect. Of course, it's a pleasure to have you. So the first question is, will the endometriosis come back after the surgery? This is the
Oh my gosh, I get this question all the time, Bhavati.
right.
It's a very, very, very common thing, which in the mind of most of people who are going endometriosis or who is having endometriosis. So again, if you look at it, I'll say that when you look at the literature, there is one thing which people need to understand: the literature is very heterogeneous, and by means is that they are clubbing the findings of the results with respect to what surgery. They're combining excision and ablation together. They're combining surgery done by a generalist versus somebody who's more trained in looking into and doing a radical surgery for endometriosis. Mm-hmm. So the recurrence risk, if you look at the literature, is between 2 to 40%, which they have clubbed. But again, when they look at the recurrence, they look at radiological evidence of recurrence, which is basically when you have a radiological evidence like endometrioma or chocolate cyst in the ovary coming back, or they can look at pain recurrence. Okay. But pain recurrence does not mean that you have endometriosis, because pain could be multifactorial.
Exactly. And I just wanted to add that a lot of patients that I see, right, And like you said, pain can have so many sources. Even if you have endometriosis and you get excision, a lot of times, sometimes when pain comes back, that starts freaking the patients out and they think endo is back.
Correct.
But that's great that you pointed out that pain sources can be a lot. And so that's one of the reasons a lot of endosurgeons as well refer patients to pelvic health physical therapy, just to look at other pain sources and treat that first before the surgery.
Sometimes we do that. Like, sometimes even like if I have suspicion of more pelvic floor disorder, then I'll tell them like start with the physical therapy. And if doesn't improve with those measurements, then we can think about endometriosis. But again, coming back to the question, like, I recently saw a patient in the clinic who came to me with symptoms of all these symptoms, and she's like thinking in her mind that endo is back. And she just had a surgery about 4 months ago. So again, coming to the thing, with the exact literature, like the exact incidence, we don't know, because if you look at literature, I can point at like, okay, the recurrence risk is 2 to 40%, but it depends on who is doing your surgery. Is it done by people who knows what endometriosis is, or they just go and ablate, which is basically burning the top and not taking the disease out? That's number one thing. Are you doing in a young patient versus an older patient? Again, the reason I pointed out, because endometriosis is a chronic inflammatory condition, and the younger you are, the higher chance that you may have a recurrence over the course of time. Again, when you look at the literature, it is not said like, okay, this is the risk at this age, this is the risk at that age, but they're all clubbing it together.
Got it. So do you say that the number one factor for recurrence would be the type of surgery, like ablation versus excision, or there are other factors as well that patients should be aware of?
I mean, again, the who's doing it, so that's the number one, like, okay, whether who's doing the surgery, that is like whether ablation or excision, and then number two is who is doing the surgery, because most of the recurrence, they are also thinking, is it the actual recurrence or it is the reactivation of the disease which was left behind? So it's a persistent disease, so just a progression of that persistent disease. So it's very important to get your surgery done by people who do this day in and day out, so that you have a complete excision and you remove the peritoneal lining, which is having the disease, so that those diseases don't progress. So I think this is number one factor, which like I always tell my patient, like the outcome, like if this person is having cancer, the outcome of having the best outcome is in the hands of experts who do a complete debulking surgery when they go. And so they remove the tumor burden. So in the same way, we remove the endometriosis burden, the inflammation burden, and then we have to look at the recurrence rate.
Got it. And I think the other thing that I also notice with a lot of patients who even get the excision surgery is that if they go to a place where the surgeon probably doesn't have a big team, like with maybe a thoracic surgeon on the side that can, look at endo if there's like around in the thorax, or maybe some surgeons are not trained to look at like the bowel endometriosis or around the bladder. Probably that could be a factor.
So many times they get their surgery, but they continue to have symptoms, and you're like, oh, they continue to have bowel symptoms, and you're like, okay, and you look at MRI, these nodules were missed. And I had like people who had, like when I was in training, I saw like a lot of people who got surgeries, and they're coming back to us, and we find diaphragmatic endometriosis, and we usually run the bowel. So in our practice, like I was trained with Dr. Watson, and she runs her bowel from small intestine, she runs the small intestine completely to look for any spots, and sometimes we find those spots. And we look at bowels closely. She looks all around the abdomen. So this is how I was trained, to look all around the abdominal wall, to look on the intestine. And the more cases you are, your eyes become adept in picking up. And the interesting thing is that even though we are so trained, sometimes we can miss endometriotic lesions too. There was a study in Mayo Clinic which said that our eyes are not as good as taking the tissue out and subjecting to pathology.
Wow. And there was a time so in 2014, 2015, I was working with endometriosis practice. Like, so there was a time when like in a day I would see like 10 to 12 only endo patients after the surgery. And I remember like a lot of, like, majority of these patients that I was seeing would tell me like this is their 6th or 7th surgery. And so I feel like hopefully now we are moving towards a place where, like, we have more excision surgeons, more experts. And so I hope the story changes for endo patients, you know, from like
True.
60.
And we also know that each subsequent surgeries, you see the effects less and less. So our hope is, like, I have a patient who have like 8 surgeries or something, like, you know, each surgery adds to your anxiety, it adds to adhesions, it adds to a lot of morbidities. We don't want to do multiple surgeries.
Exactly.
I want to avoid it.
Yeah. Okay, thank you so much for that. So my second question that I get most asked is, what about the birth control management, hormone management after the surgery?
Again, a great question. And we looked at the literature. There's no consensus as to do you recommend it as a gold standard? Like, yes, you have to do it, or should you be like, okay, you can just let it go? For me, when I look at it, I think it's a team approach between the patient and myself. And endometriosis is such an enigmatic disease that, yes, we know something about how does it recur and what is happening, but yes, we don't know much of the disease. Our understanding is still evolving. So when I talk to the patient, I work as a team with my patient, because some of the patients don't like to take birth control pills for various reasons. Mm-hmm. And so in that case, and if I have done the surgery, I know that I have done it complete excision, I will not tell you to take the medicine, because I do understand that it can have some negative impact on you. If you're someone who is who doesn't like your period and is okay taking birth control pills or an IUD, I would have a discussion with them, especially with adenomyosis, mm-hmm. because, and I'm doing a hysterectomy saving procedure, I would not like you to be like, adenomyosis can still be painful. Right. You know, you can have painful and heavy cycles. Right. And if I were you, I would be like, okay, I don't want this heavy painful cycle. Then I bring a discussion about an IUD versus the birth control pills. In those cases, I will suggest that you should take it. But again, if you're totally against it, for some reason, I'm not someone who will be like, hey, you need it. And the advantage of birth control or IUD is also that it also prevents your ovulation pain, things like just painful and it's uncomfortable. So if you're okay taking it, go for it. But if it doesn't line with the goals, which could be you need fertility immediately, I'd be like, go off of it. You don't need it.
Got it. And then there is a discussion about like different hormone pills as well, like different kinds, you know, mm-hmm. Estrogen, progesterone. Is there any guidelines for that, or?
So if you look at some of the studies, suggest that progesterone is a better mm-hmm. medication, because endometriosis is like an estrogen dependent condition. So you do want to bring the load or the burden of estrogen, and that's where even the combined birth control pills can reduce the level of the estrogen, because and then you provide it from the outside. So some studies suggest that progestin may be a better role. So in the form of IUD, you can just take norepinephrine, which we typically use. So you can do that. That can also be useful for preventing any further recurrence. Better than, some people suggest it can be better than birth control pills, like combined.
Thank you
the one
so
that
much.
has got estrogen.
Thank you so much for that. And the reason I wanted to bring up this question is that, so in what I've seen is that patients go and have surgery, and then they are a little bit lost when it comes to management of aftercare of birth control. So a lot of the times, these patients after the surgery will go to their regular GYN, who then prescribe birth control. And when they come and ask me, like, like, I don't know now what to do. I'm going back to GYN.
Yeah. So and to take away, Yeah. So to take away, I'll say that progestin is always better. And if you're taking the combined birth control, which has both estrogen and progesterone, then a continuous suppression or a continuous medication is definitely better than just doing like a cyclical one. But again, it's totally up to you. If you feel comfortable, take it. If you don't take it. Sometimes I prefer an IUD over a pill, because pill is something hard to take for me to remember. IUD is something which is local, doesn't have much mood swings or the hormonal side effect which people experience, because it's very local, very minimal level of the hormones in the blood. So, and you can keep it for 5 years. So.
Okay, thank you. And I think another reason a lot of surgeons do suggest IUD at the time of surgery is that, like, you're already under, so the pain is.
Mm-hmm. Definitely, that's an added advantage, because doing an IUD in someone who's already having painful intercourse and pain in the pelvis, it's not an ideal condition to do in the office. So you're already under, you can get that. And sometimes people also inject a pelvic floor called trigger point injection at the same time, so it kind of gives them a complete relaxation of this floor and can help with the post-op pain and further recovery.
Perfect, thank you. I feel IUD pain and the protocols are a whole nother topic, but I feel thank you. My third question is that what about recovery guidelines after the excision surgery? Are there, I know there are no set guidelines, but what are the pointers you would give patients? What are the things they should look out for?
So endometriosis surgery is an outpatient procedure, so you will be going home. I do my 99.9% of my patient goes home. I always tell them that pain is expected. Take it easy. Pain will not be at zero. Some people come with pain. Their pain level is already 5 or 6 before they're going for surgery. So I don't expect the pain to be zero, or as long as it is manageable for them to control the pain with pain medication initial few days, that will be good. Always watch out, and whenever you do a surgery, even in the hands of a good surgeon, always watch out for symptoms like uncontrolled nausea, uncontrolled, like you're not able to keep anything down, fever with chills, fever especially more than 101. Light fever, like 100 degree, 99 degree, it's normal to have Fahrenheit. I'm talking Fahrenheit. It's very, very normal to have that, because of various reasons. But fever more than 101 degree is something you should be worried about, and you should inform your doctor immediately. For the first few things, I'll say that don't try to be like, yes, we had a surgery, we have small incision, and most of the time I see people like after 2 weeks, they're like, oh my gosh, I'm feeling so one, and they start doing everything. So try not to lift heavy stuff. Again, there's no guidelines, but if I'm a patient, I want my fascial incision to heal so that I'm not going for a second hernia surgery later. Again, the incision is small, the chances is maybe very low, but again, if I'm a patient, I want to be treated with love at that time. I want to treat my body with love, so I would say take rest. But rest doesn't mean like a bed rest. Move around, listen to your body, and as long as your body, whatever your body's telling you, just listen to the body. You can take the stairs. You can also walk, but don't start walking on a steep, like a hilly slope or something. So just listen to your body, take it easy, and go from there.
Thank you so much for that. We recently met at the hospital with Dr. Vidali, and so I was seeing the patient post-op, like right from week 1, and she was feeling great after the surgery. And I think that's exactly what I pointed out, like, you're feeling great, but still, let's take it slow.
Yeah, and anesthesia is not, I mean, yes, anesthesia is advanced, but anesthesia is like drinking a whole bottle of wine. Exactly. So you will recover slowly, and you will feel fatigue. Many of the patients were like, oh, I was feeling so well, but why in the afternoon I'm feeling so slumpy? Yes, you will. I always say, have grace, like give your body some grace, let it heal. And it may take about 6 weeks to 8 weeks before you feel that, okay, you're normal again.
Yes, and I think the other factor is like, so many, like, patients are on heavy pain medication, so you might feel great when you're on, but then you also want to just wait when you start weaning off the pain medication and how you feel before.
Yeah, when again, like when you're in pain, you will time it, but your day goes by and you haven't taken a medication, that means you're doing great. And most of the time people don't need any narcotic. It's just Tylenol and ibuprofen, and mostly they can do a muscle relaxer, but most of the time people don't need narcotics. And first 3 days maybe a little, you may feel a little bit more pain than usual, but after that each day gets better. But again, look for those unusual signs and symptoms. If you're feeling like a blah or something is you feel that this is not going right for you, and those symptoms which I pointed out, especially like pain in the calf, like a swelling in the leg, or fever and all those things, then you should inform your doctor.
Perfect. Thank you so much for those. Very helpful. So in this slide, we talked about 3 top questions. One is the hormone management of the endometriosis. Will the endo come back? That's another top question that we get. And then pointers for recovery after the surgery, things to look out for. Thank you so much for Dr.
Thank you, Bhavti. It was great. Bye.